Here we're going to have Dr. Berger and Ben Greenberg from the University of Texas Southwestern discussing best practices in contract negotiation and knowing your worth as an MS specialist. So, gentlemen, take it away.
I want to thank EMD Serono and Academic CME for this program. We're going to talk about what a neurologist is worth. And how, the first part of this is going to be educating you about your value. It is going to be more addressed to those individuals that are going to be joining academic centers or group practices. If you're going into private practice, which is, by the way, a rare breed, probably not quite as significant, but you'll learn something from this. So why don't we get started? Knowledge is power, as Hobbes said. And when you go through medical school, you do not learn the economics of medicine. This is something that took me a long time to learn. And in large measure, I learned it not when I was a junior faculty member, but I learned it when I became a department chair. And by the way, for those of you like Fiona and Mark that are from another country, this is going to be a foreign language to you. We have a very Byzantine, strange system of medical economics in the United States. Maybe one day it'll change. So data by Matt Rizzo and Bill Mobley collected 20 years ago showed that 73% of neurology departments operated at or below break even, that 83% of them were under severe or moderate financial pressure, and that 17 had severe difficulties making ends meet. Interestingly, only 15% of departments generate a profit from patient care. In fact, a third of them were losing $40 per patient per visit. Hopkins was a good example of this, by the way, from my conversations with them. And as a consequence, there was less time for research and less time for teaching. Things really haven't changed, so this was looked at again in 2019 by Robin Bray and Ralph Sacco and others. And what they found is that departments of neurology, and this is true in group practices as well, sometimes found it quite difficult to make ends meet. That 70% of the faculty salaries paid by clinical income, 20% came off grants, and the financial pressure was graded as moderate in 58% and severe in 13%, with a significant impact on resident training and student evaluation. Now, where does the money come from that supports medical schools and departments? And by the way, there's no department of neurology in the United States that exists independent financially, which means that there's always transfers of money that come from either the hospital with which you're affiliated, the medical school, or usually both, back to the department to make ends meet. And that money comes from a variety of sources, not the least of which, as you see in brown and green on this slide, from federal sources. Now, this slide ends in 2019. You'll see that the amount of federal money coming to medical schools declined in that period of time, 20-year period of time or more, but it is going to be, or is threatened to be, severely constricted under this new administration. And I think it's going to have tremendous ramifications for those individuals that are practicing academic medicine currently. Now, here's something that will surprise you. Between 1975 and 2010, the number of physicians in the United States grew by 150%. And if you kept track of the number of physicians that were added to medical staffs, by and large, it was relatively flat, and it was very flat compared to what one saw with respect to administrators. So the number of administrators in medicine between 1975 and 2010 increased 3,200%. So you wonder where all your money's going to. It's going to overhead for all these administrators. And I will tell you that some of these administrators with college educations no more are making more than junior faculty members at many of the medical schools. So what is the average pay of a neurologist in the United States? And on the bottom half of this slide, you see that the neurologist, so below that green bar. And you'll see those that have the lowest pay are those that are at academic medical centers. So the solo practitioner and those at academic medical centers have the lowest incomes. Those that are in hospital-based practice groups tend to have a higher income. And where does the MS neurologist fit into all this? And there's a paper that I published in MSARD that addressed this. But it turns out that the physician that practices neuroimmunology and multiple sclerosis is towards the lower end of the scale amongst neurologists. So top of the scale is the neurocritical care person. This, by the way, comes from AAN data. The next highest was the neurohospitalist, then surprisingly the general neurologist, and you'll see that the MS neurologist, the average salary for the MS neurologist is significantly lower. That, I think, has to do with, in large measure, because of historical factors. Because up until the availability of disease-modifying therapies, we would spend a lot of time with patients, we had very little to offer them, and we didn't generate much in the way of downstream revenue. And I'm going to talk about downstream revenue and how important it is to what you should be arguing for when you negotiate a contract. How do you get paid? Well, you get paid in most instances on the basis of what's called the relative value unit. And I'm going to tell you what the relative value unit is in a second, but about 70% of individuals or more, 70% of institutions use either relative value units alone or relative value unit in combination with something else to determine what your compensation is going to be. So you're going to have a target for your, if you're predominantly a clinician, a target for your relative value unit that you have to meet. If you exceed it, you may get a bonus. If you don't meet it, they may decrease your salary. So how was the relative value unit determined? It was determined by the Centers for Medicare and Medicaid in consultation with Specialty Society Relative Value Update Committee of the AMA, and it reflected three cost components. And these were related to the physician's work, their time, skill, and training to provide the service. So the physician's work is 52% of the total payment, the practice expense was considered 44%, and the professional liability fee 4%. And this is, as I mentioned, widely employed in determining productivity. So 75% of neurologists receive their payment from evaluation and management codes, and 20% of all neurologists receive all their payment based on these ENM codes, the evaluation and management. The RVU targets are set annually by the academic health centers, and they may be very difficult for MS neurologists to meet. And the reason they're difficult for us to meet with respect to other types of neurologists is because of how time-consuming our patients are. It's one thing to see a headache patient or a seizure patient. You can get them in and out of the office very, very quickly. For many years, I practiced general neurology, and I could tell you that amongst the more difficult patients and the most time-consuming patients are the MS patients. So here's a concept that you need to know about, and it's called contribution margin. What's your contribution margin? Does anybody in this audience know what the contribution margin is? It's the profit, your profit, what it is you bring to an institution over and above your cost. So you bring in a certain amount of money, and that's not just based on what you charge a patient, but it's on what that patient, how much monies are derived from that patient in the system. So you order an MRI for a patient. The University of Pennsylvania, it's like if you didn't have insurance, it's $10,000 for an MRI, you know? There's a certain profit margin in that. If you get lumbar puncture, if you do laboratory tests, if you send them to another doctor, there's a profit that is derived from your seeing that patient. And that's the contribution margin. Very few doctors understand this concept of the contribution margin. When it was calculated by Merritt Hawkins in 2016 for the community neurologist who was associated with a particular hospital, they found that they generated on average about $1 million. I'm going to show you that at the University of Kentucky, that for the average neurologist, it was roughly $2 million per neurologist. Now, how was that calculated? At this time, I had been a department chair at the University of Kentucky for 16 years. We had 29 providers. Their clinical time was 60%, so on average. So some were 90% clinical time, some were 10% clinical time, but on average it was 60% for those 29 providers. The value that I'm showing you here does not include the revenues that came in when a patient paid for your services, but were the components that were derived from the ancillary things that you did. So the technical facility revenue per provider was over $1 million, and the professional net revenue per provider was close to $50,000. In the aggregate, I misstated it, was $1.8 million in '82 when you corrected for the fact that they were only 60% clinical FTE. And it was close to $2 million that every neurologist brought in to the institution from these other ancillary activities. We don't think about those things. We think about, we see a patient, we bill for a service, we get paid that amount, but there's large sums of money, and I'm going to show you, that come in from our activities. So these are some of the sources of revenue other than the E&M codes generated by MS clinicians. They include the laboratory studies we request, the MRIs. At the University of Pennsylvania, 25% of all MRIs are ordered by the MS division. Evoked potentials, optical coherence tomography, lumbar punctures, the disease-modifying therapy. So if your pharmacy is providing the drugs, there's a huge potential profit there. There's a profit regardless, but if they are operating on something called a Medicare 340B, so this is a law that was enacted that enabled hospitals that were providing a certain amount of indigent care to get, on average, 50% of the cost of a drug back as profit. So assume for the moment that the drugs you're ordering are $60, $70, $80, $100,000 a year, and the hospital is providing it, and they're getting 50% of that back. You don't need that many patients in your practice to generate large sums of money for the institution. Of course, there's the follow-up evaluations, and then the consultations, which are the professional component of it. So you see a patient, they've come to see you uniquely. They come to the Cleveland Clinic to see Jeff only because he's the MS authority, or to Mount Sinai to see Fred because he's the MS authority. They're not coming there for any other reason, but these people say, you know what, you need to see a urologist, you need physical therapy, you need these other people, professionals to see you, and it stays at the institution. They wouldn't be at that institution if it hadn't been for you. So these are data from AHC, so there's Medicare-derived data of what the profits are on average for these studies. So MRIs, $1,000 battery of evoked potentials, $250, and so on and so forth. You can see what they are. I won't belabor it, but they're not insignificant. So in 2017, I published this paper in Neurology Clinical Practice. The derivation of this paper was interesting because at the time, this is before Amit came to the University of Pennsylvania, or just about, I was the division chief, and I went to the department chair and I said, can you tell me what the contribution margin of the division is? And she said, they don't calculate that. First of all, she didn't know what it was, but when I explained it to her, she said, they don't calculate that at Penn. I said, come here. That's the hospital of the University of Pennsylvania. They operate at that time on a 9% margin, which is higher than any hospital in the United States. And that's Wharton Business School, which is the best business school in the world. Trust me, they know the contribution margin of the department, the division, and Joe Berger. And all it takes is a press of a button to get that. So I did with back-of-the-envelope calculations, because nobody would provide me the data, what an MS neurologist would generate. There is an Excel spreadsheet. You could do it yourself. And then I said, how many patients does one clinical FTE, one full-time equivalent clinician in the MS division at Penn see? And on average, that person was seeing 325 new patients and 700 follow-up patients annually. And then I calculated how many MRIs they were doing, how many evoked potentials, how many OCTs, et cetera, and whether they were asking for, whether the drugs were being provided at the University of Pennsylvania. And it came to roughly an annual revenue for the institution of $6,310,000. And then the paper had a sensitivity analysis, because not everybody gets every study, and not everybody gets their studies at the University of Pennsylvania. They may get them at some other facility. So there was a sensitivity analysis that enabled you to sort of figure out where you would be, how much you would be generating if only 50% of the patients, for instance, had their studies and had their drugs provided at that institution. And the same thing was done with follow-up patients, and calculated that $22 million was being generated for the follow-up patients, and a sensitivity analysis was associated with it as well. And then there were some assumptions, like how many of the patients had their electrodiagnostic studies done at the institution, how many of them had their lumbar punctures done there, and so on and so forth. And what I calculated was that the amount of downstream revenue for the institution per one clinical FTE MS specialist was $1.7 million for new patients and $6.6 million for follow-up patients. So an MS neurologist who's working 100% clinically, that the aggregate downstream revenue was $8,377,000. Well, it turns out that we were almost on target. What actually happened is that the institution, after this paper was published, revealed to the department chairman, all the department chairmen, that they were indeed calculating the contribution margins, not only for divisions and departments, but also for individuals. And the numbers that I had generated were almost to the penny, and I had made them up. I mean, it was good reason to make them up, but they were just back-of-the-envelope calculations. It turns out that the MS division at the University of Pennsylvania, and this is probably true at every institution, generates more money for the institution than all of neurology combined. More than epilepsy, neuromuscular, stroke, critical care, all of them combined cannot equal the revenue that the MS division generates for the institution. Not only that, we generate more money than spine surgery. Yet our compensation is nowhere near that of the spine surgeon, and is not as good as the neurohospitalist or the critical care or the stroke neurologist. So on average, in 2013, I don't think the number's very different now. If you look at the monies you generate and the amount that they pay you, that's a ratio. And they look at that, that's called revenue to compensation ratio. And the revenue to compensation ratio for the average hospital-based neurologist in the United States is 2.47. How does that compare to the rest of the medical community? So this is some data that's available online. And in 2015, a neurosurgeon's revenue to compensation was 2.5. An orthopedic surgeon was 5.17 to 1. An invasive cardiologist, 4 to 1. And a hematologist oncologist, almost 5 to 1. At the University of Kentucky, using the figures that I had generated in 2012, the revenue to compensation for an academic neurologist was 6.2 to 1. So we were getting screwed relative to the neurosurgeons. But to show you what it is for the MS neurologist at the University of Pennsylvania, and by the way, you can get this Excel spreadsheet and put your own numbers in. For the MS neurologist at the University of Pennsylvania, it's 44 to 1. So, I mean, it's ridiculous how much money the MS neurologist is generating for the institution. And I tell you this because when you go to negotiate your contracts and you're trying to negotiate a salary and to demonstrate how much worth you have inherently for the institution, these are the numbers you should be showing them. So the take-home message is that the downstream revenue of the MS neurologist dwarfs that of all other disciplines. And there are certain caveats because there are certain things that I didn't include in the compensation. But you need to know these things because, as Dale Carnegie said, knowledge is power, but it's not power until it's applied. And I'll stop there because we're going to go through a bunch of other things that you need to talk about when you negotiate your contracts. And I'm going to turn it over to Ben.
Thank you, Joe, and to the organizers for today for hopefully what's going to be a slightly different set of talks that you're used to hearing at a CME event. But just by show of hands, how many people in the audience are trainees, residents, fellows, students, somebody who hasn't signed a first contract yet, just out of curiosity? Okay, so a large number. So I want you to think about Joe as your sports agent telling you how valuable you are. And you need to go in, and I almost had a picture from The Godfather. You need to make an offer that they can't refuse because you are highly valuable. And then I'm on the other shoulder saying, there are some realities you're going to have to take into account when having these conversations in order to maximize the deal you get from a holistic perspective. So how do you go about negotiating your contract? I'm going to talk about a few things. One is recognizing that the contract you negotiate is completely dependent on the practice setting. So a lot of what we're talking about today is in an academic center. I'm going to give a few comments about the private practice setting, but most of this will focus on the academic side. Recognizing there are very different payment models out there. There are no two institutions or practices that are alike. Joe talked about RVUs and the benchmarks, but I want to talk about some of the other aspects of a contract beyond dollars, beyond compensation that you need to be aware of. The first thing that's important when negotiating a contract, whether it's with the University of Texas Southwestern or a practice, is to recognize what you're selling. We are not making widgets. You are not manufacturing cars. You are not putting together circuit boards for computers. You are selling your brain. And what I mean by this is you are the sum total of your incredible training, experiences, both professionally and personally, your work, your study, those hours in organic chemistry, all the way through neurosciences, on the wards, with your patients, with your faculty, and all of that has come together to be a one-of-a-kind, not reproducible, unique asset. and that's your brain. And what you're selling when you sell your brain is where you can focus your attention. So for everyone here who's multitasking during the event and answering some emails and doing some text messages, that multitasking is taking away from attention. And in the workplace, people are vying for your brain's attention. Whether it's the patient in front of you or a person on a research project, or you can decide to spend half a day updating a Facebook page, your attention is the asset. And you have a lot of customers for that asset. So you have health systems who want your brain's attention. You have individual university departments, students who want your attention in schools, industry, they want your attention. Taxpayers may want your attention through funded grants. Foundations, nonprofits may want your attention, again, through grants. And ultimately, patrons through philanthropy may want your attention on different prospects or on different projects. And you have to decide where to put your attention, and I'm going to be frank, you have to have a way to monetize it unless you want to be a volunteer. If you want to volunteer your attention, which I encourage us all to do, there are many causes in life where we shouldn't ask for remuneration for our attention. You have to decide how far to go with that. So assuming that you want to be remunerated, you are selling that attention. So this gets to the notion of percent effort. So especially when you're talking about academic centers, we talk about percent effort all the time, but most people when they're starting out think of it as, how many days a week am I in clinic? And that is not the way to think of percent effort. Percent effort is essentially who is paying for your attention. So if you went out into the world and you decided to spend half your professional life working at McDonald's and half your professional life working at Burger King, you would get 2 paychecks. Half your salary would come from one, half from the other. In an academic center, there are multiple people paying your salary, multiple entities paying your salary. It gets aggregated into one paycheck that gets deposited every other week or monthly into your account, but essentially you have multiple employers, and that's what gets broken down into percent effort. There are entities who will pay for your clinical attention. There are entities who will pay for your educational attention and teaching, research, and administrative. And what you do is you negotiate what you're going to get for that attention. Joe just showed you the incredible value you have clinically to a health system. You're worth millions of dollars to that health system. So every half day you spend, every 10% of your time you spend seeing patients, somebody somewhere is making money. It may not be you, but somebody is making money. So you better believe a health system is going to say, I'll take all your attention. You want to give me 90% of your attention? I'll take it. You want to give me 80% of your attention? I'll take it, because they know that is going to help them financially. That may not be best for you. You may want to decide that you want some of your attention, some of your professional time spent elsewhere. How do you monetize that? And when first starting off, a lot of people go to university departments and they go to chairs with their first negotiation and they ask for the most valuable phrase in academic neurology, protected time. And essentially it's asking for somebody in the world to say, you are such a rock star, I'm going to give you this pile of money a year, every year for some amount of time, for you to go do great things. And it sounds amazing. And it sounds great not to be in clinic 5 days a week, 8 to 5, and to have some diversity in your life. But you have to recognize that what you're asking for is extremely valuable, and the entities or individuals you are asking for it from are essentially venture capitalists. This is Shark Tank. So when you go to a department chair and you say, I would like a certain amount of startup funds for every year for 3 years to get my program in lifestyle modifications in the MS patient population, and I want to start a program on lifestyle modifications, they have to ask themselves, is it worth the investment? Because our chairs, and I'm sure Joe can attest to this, get a lot of pitches every year. There are a lot of people with great ideas coming in saying, invest in my idea, invest in my brain, invest in my time, I'm going to do great things. And you don't get these funds for being a nice person. Unfortunately, that would mean we'd have to fund all of you because you're all wonderful people. But we are looking for, and chairs are looking for, a return on investment. Now, that return on investment, if it's a clinical program, could mean growth of those downstream revenues. So a health system may invest in you to build a bigger program. On the research side, if you're invested in protected time for an academic pursuit, the person investing, the entity investing, expects you to return that investment with future grant funding. That's how they make their money back, through the indirect dollars that come with the grants that you successfully navigate. And they have to ask themselves, where are they going to place their money? They're going to place it with individuals with a proven track record. If you can invest in two wonderful human beings with great ideas, but one of them comes to you with a track record of success and one of them doesn't, where are you going to put your money? I'm assuming if you have a mutual fund, you're all looking at how the fund performed over the last 5 years and using that as a benchmark. Great ideas alone are usually not enough. Great ideas need to come with proven track records, or you have to have a very hot, timely, interesting area of unmet need that you can sell as being valuable. But it has to be something substantial. So what about private practice compensation? This is completely different. So in the academic center, there are lots of different buckets that can pay you. In private practice, it is directly related to clinical revenue for most intensive purposes. But you have to recognize if you're going to go into private practice and you're going to negotiate a contract, there are several different compensation models out there. Some of them give you a guaranteed salary. Some of them give you a salary based on revenue. So you see the funds that are brought in the aggregate and you share in that. And some of them use an RVU production model and potentially a hybrid. You have to have clarity in what you're being offered, and you always want to ask, how could this go down in the future, or how could it be prohibited or impaired from going up in the future? I'm not going to go into time on the RVUs. Joe showed you this data, but needless to say, this MGMA, the Medical Group Management Association, that publishes a 3-year rolling average of how many RVUs get generated by neurologists, goes into incredible detail. They can say a neurologist in a private practice in the southeast of the United States, the 50th percentile, will have 4,900 RVUs. And you can backtrack exactly how many patients would you need to see over the year in order to meet those benchmarks. So what about beyond salary? And this is where I'm going to end, because there's a lot to negotiate on compensation, but there are some things we don't think about. Paid time off. What are the policies and procedures for you being able to take a break and have coverage? Taking a break and answering all your My Charts is not a break. So when you're trying to decide what is paid time off, what is the policy and how is coverage there? I cannot stress enough, especially in the academic side or the private practice side, beyond your compensation, what does the institution or the practice do to administratively support it? Now, Joe just told us that administrators have exploded, and there are 2 levels of administrators. There's clinical staff support, which are the people who help you get things done. That's different than the administrators I think Joe's talking to, who are doing a whole host of other things that I haven't figured out yet. But for those who are in the clinic with you, having really good partners on the healthcare team, advanced practice providers, RNs, MOAs, people in the clinic to help you shoulder the burden, who are good at what they do and are not just moving messages to you, but are actually engaging in patient care, makes a huge difference. Licensing fee reimbursement, will they pay for your license? A lot of people assume they will. Ask before you assume. It's very variable through the institutions. CME time, and is there funding? So at the University of Texas Southwestern, there's a faculty academic fund every year to pay for meetings like going to ACTRMS or the American Academy of Neurology. You want to understand the rules about that because that's tax-free dollars. That's an expense you would bear, but it's not coming as salary and can be quite helpful. Non-compete clauses. So as you're looking, particularly whether it's academic centers or private practices, just know sometimes things change and you may want to change your practice setting. Now that's not true at UT Southwestern. Everybody who comes to us stays because we're awesome, but sometimes you may go to another center and be like, wow, this wasn't a great fit. I'm going to make a change, and there are some institutions that put non-compete clauses, meaning you cannot set up a practice within a certain number of miles of where you started. In general, a lot of lawyers, which I am not, have told me these are not really enforceable. And so there are a lot of people saying, you may sign the contract, but still set up a practice a mile away. But definitely seek out legal advice, not Ben Greenberg advice, if that's in your contract. And then finally, my favorite, parking. So when our faculty, this goes back years in Baltimore, were surveyed on their #1 dissatisfaction with the institution, parking. Was where am I going to park? How close am I to the place I'm going to work? And is somebody else going to pay for my parking? And after all we do, I always found it funny that this was the thing that people at faculty meetings would get more upset about than anything else. So if it's important to you, consider the parking. And the point that was made was there are certain things we do day in and day out, and it's the little things that add up. If I had to put on this list, even beyond paid time off, even CME funds, anything else, the one thing I wish I would ask when negotiating a contract for a new position, it would be to understand in depth what is the staffing support of the environment I'm going to work in. The biggest impact on my day-to-day professional quality of life is the team I work with. When you're in the room with the patient, whether it's for 5 minutes, 15 minutes, or an hour, that doesn't change where you work. That physician-patient interaction is going to be about you, but it's everything else that happens that changes dramatically relative to the environment where you work.